I'm Sonia Azad. Welcome to The Shift. Real connection, healthy conversation as we navigate life's changes and challenges together.
Today's podcast is sponsored by my good friends at Fertility.
Hair and makeup generously provided by Glam House Collective.
Hi, I'm Sonia Azad. Welcome to The Shift. Today we are talking all things fertility preservation with Dr. Katie Doody from Fertility in Bedford, Texas, which is in the Dallas-Fort Worth area. Thanks so much for joining me today.
Thank you for having me, Sonia. I'm happy to be here.
Yeah, it's good to see you. And can I say that you just recently had a baby?
I did, yes.
How old is she now? She's
6 months.
6 months.
Yeah.
And how is it being a new mom?
It's been wonderful.
Yeah.
It's been really great. She's our first, and I feel like it's really expanded how I feel about being a physician and certainly being a fertility physician.
Yeah.
Like what I do every day is talk to people about building their families, and I feel like it has really, depthened how I feel about everything. It's been really great.
Yeah.
Yeah.
And so give us an idea of your background, how you got into this work, which is really, I have to mention, a family business because your mom and your dad are both fertility specialists.
Yeah. I was really fortunate to grow up watching my parents doing this exact same job. I will never forget being a kid and going out to eat as a family and a couple coming up and saying, "Oh my goodness, Dr. Doody, this is our daughter, this is our son, and you helped us have them." And I think I kind of understood at the time, and as I've gotten older, how incredibly impactful that is I think it's just the most amazing thing in the world is to help people build their families.
Mm-hmm.
I have known a long time that I always liked science and I always liked helping people, and I did my undergraduate at Rice University. I studied history, and then I did my medical school at Baylor College of Medicine in Houston, and I knew from that point that I wanted to do something in women's health. I always tell people I didn't want to go into the fertility, world and be an infertility specialist only because my parents do it, but I didn't want to not do it because my parents did it, and I wanted to really kind of see everything. And so I fell in love with women's health as a medical student, and then came to Dallas to do my OBGYN residency at UT Southwestern in Parkland, which was incredible. And then at the end of the day, it really was what I wanted to do. I wanted to be an infertility specialist. So did my fellowship training at the University of Southern California.
Wow. Mm-hmm. Incredible.
Yeah.
And so I was trained as a health reporter to start calling it fertility, not infertility. But what do you guys use? What word do you use, or does it matter? Do you interchange them?
That's a great question. I probably tried it same like you said. I probably try to say fertility more than infertility. I think probably they're used pretty interchangeably.
Mm-hmm.
In some sense, I feel like talking about your fertility can be almost a more proactive
Mm-hmm.
sense.
Yeah.
And talking about infertility, which I think is maybe a diagnosis that's made kind of like in the rearview mirror after I've been trying for a while.
Yeah. And it makes people feel like there's something wrong with me. There's something broken about me. There's something not working right.
And I think I agree with you. I think that's often something that I hear from patients, and I want people to feel like they feel comfortable talking about the experiences they're going through, and should not feel that burden is on themselves and something that they've done wrong. It's unfortunately really common. Couples having difficulty conceiving. Infertility is about one in six couples.
1 in 6.
Mm-hmm. So it's really common worldwide.
So by the time you see someone, what have they done and what have they not done? What have they been through?
I think that varies by couples. We see a variety of different things. So definitely we see a lot of couples who come in who kind of meet that classic picture of infertility, have been trying for a long time and haven't been successful trying to get pregnant. But we see a lot of patients who come in and maybe they're deciding they want to build their family using donor egg, donor sperm. They're single women, single men, same-sex couples. We see couples coming in who have a known history of carrying a genetic condition and decide they want to do IVF to avoid passing on diseases. So there's a lot of different types of things that we see. I guess to get to the point of your question of like, what are people doing beforehand? I think a lot of times people are meeting with their primary care doctors, their OB-GYNs, getting a sense of where their health is at and talking to them from that standpoint, and then often coming our way.
What's one of the most common sort of I don't want to say problems, but issues that you see? Like there's always this like a speed bump or an obstacle, let's call it, where people feel this sense of maybe desperation that's like led them to you. Is it just we've been trying, we can't have this child, we can't conceive?
Yeah, I think that's the most common thing. And that can present either someone's trying for their first child, or sometimes also frustrating. They've had a child in the past and didn't feel like they had difficulty conceiving, and they're trying to expand their family.
I am so glad you said that, because that's something that's rarely talked about. It's typically around this framework of we can't have children at all, but we're sort of forgetting in that discussion this population that you just brought up, which is, no, we have children, we want more.
Yeah.
And so what happened? Is it just age, or is it other things that, like, other factors that can play into it?
It can be a variety of different things, for sure. I do think age plays a really big factor. So it's definitely a lot harder to get pregnant as we age for a variety of different reasons. But our health can change over time, right? I mean, the time frame in which women and couples have families is over a pretty wide span of time. And so something that, may change in our health may be different from what was like in our 20s or in our 30s.
What are the markers of health that you would say, from your standpoint, are important to keep a close eye on as you're aging? If, you're thinking about having a family one day, having your own biological children, what are some of the things that we should be just at least tuned into?
Yeah. So, I think women are having children at an older age now. So, thanks to the advent and use of donor eggs. So even beyond the time frame in which someone might be able to get pregnant with their own eggs, they might be able to have a pregnancy in their late 40s and 50s. I always think it's really important for patients to really be focusing on healthy lifestyle in general, right? So I think a healthy lifestyle is going to help, certainly help you have a healthier pregnancy and healthier long-term outcomes. I think there's not a particular lifestyle necessarily that's going to say, be the end all be all for somebody's fertility. But I think focusing on things like, eating healthy, exercise, trying to get good sleep, all of those things I think are really important and start to add up. You asked about like what are things that we should be looking out for. I think having good heart health, cardiovascular health as women get into the older like ages in their 40s, or if talking about like pregnancy in their late 40s, I think that's definitely something to be considering.
Yeah, because I don't like this term of, I don't even know if people still use this, but the geriatric pregnancies above a certain age was like 35. Is that still what it's called?
Certainly don't use that, and I don't really know any other physicians who use that, but I have heard people say
it's kind of archaic.
It is very archaic.
But for the people who are, let's even call it like in their late 30s, early 40s, the complications, when it comes to high blood pressure or even the postpartum complications, like that gets a little sticky the older you get. It's not as easy. I mean, even, I do not know from experience. I have heard it is not as easy to have children later in life.
So there are some increased complications that can happen, or increasing risk as women get older with getting pregnant. So just like you said, there's increase in high blood pressure in pregnancy, diabetes at pregnancy. You're at higher risk of having a C-section for delivery. But all that to say, I think a lot of women in their 30s and 40s go on to have very healthy pregnancies. I think it's important to, again, try to live a healthy lifestyle, to try to minimize those risks as much as possible. But most women still go on to have healthy pregnancies.
Yeah. And that's a good reason to maintain your health, is to just make the process smooth sailing as much as possible. Yeah. I want to know where you feel technology is right now, and then where it's going. So we know kind of what it's looked like in the last 10-ish plus years, but how far have we come? And then like what's being looked at and studied, like what's coming next?
Yeah. So I think, technology for assisted reproductive technology, or ART, which is what we practice, but specifically IVF, I think has improved substantially over the last many decades since it's really, started. I think over the last decade, one thing that's really significantly improved has been doing genetic testing of embryos prior to pregnancy. really the real purpose of doing genetic testing of embryos is not to ensure a healthy pregnancy or healthy baby necessarily. It's trying to see if the number of chromosomes inside of an embryo is normal, which is going to be most likely to implant and go on to be a pregnancy. And because of that, I think chances of success have gotten a lot higher. I think that more and more clinics and physicians are transferring only one embryo at a time. And so that's meant that there's fewer and fewer twin pregnancies or triplets or more, when I think that was much more common in the 90s and even early 2000s, has led to healthier and safer pregnancies. And so I think that's been really great. I think continuing advancements in the kind of realm of genetic testing, I think is going to really continue to improve, I think, in our field.
Is America the leader, or are we at the forefront of reproductive health and assisted reproductive technology, or is there someplace else that we are looking to go, wow, look what they're doing over there, that's really interesting?
Yeah, I mean, I think there are lots of places around the world that are also leading in different aspects of infertility. For example, there are parts of the world where they're working on doing something called in vitro maturation, where it is a process involving IVF that would potentially allow for women to have less medication and fewer days of stimulation, which I think decreases side effects and takes a lot of the maturation process and a lot of the technology that happens in the body during IVF actually into the laboratory. So that's something I think that is really improving in different parts of the world. But I think that a lot of the U.S. is also trying to work on that as well.
That's interesting. I know that this is going to be a very basic question, but I think I hear people tripping up on this a lot. So let's just talk about the difference between egg freezing and freezing embryos. Again, basic question, but a very important one to understand. We got to understand the difference here.
Yeah, absolutely. I think when it comes to something like fertility preservation, I think a lot of people think immediately of something like egg freezing. The single woman who has not yet found their partner and thinks they want to have children in the future who wants to freeze eggs. And I think that is probably one of the most.
That is what I think of too.
That's the classic picture.
Yeah.
But I think that when women and couples decide to do fertility preservation, it can be for a variety of different reasons. So it may not just be a single woman who's deciding that they want to try to improve their chances of getting pregnant in the future. I certainly see couples who come in who both of them are in a phase of life where they don't feel that they're ready to have a baby, but they know that they want to build a family together in the future. And so they might decide to undergo the process together in order to freeze embryos. So both egg freezing and embryo freezing they're essentially a very similar process. They start off the same. It's a process where somebody takes medications for 2 weeks that stimulates their ovaries, and then they undergo a procedure called an egg retrieval with an ultrasound in order to retrieve the eggs from the ovaries. If someone's doing egg freezing, then the process kind of stops right there. The embryology lab will freeze eggs at that point. If someone is deciding to freeze embryos, they'll combine their partner's sperm or potentially donor sperm, if that's what they want to do, in order to create embryos and then freeze them at that point after fertilization has happened and embryos have been watched in the lab for about a week.
Okay. So, and again, I like to be transparent.
Yeah.
So I share with people, I mean, it's out there on the internet everywhere, that I did do egg freezing, went through the whole process at 35. And it was easier for me than I thought it was going to be. But at a time when my friends were all kind of like whispering about it, like everybody was like, have you done it? Do you know what this feels like? Do you know what this looks like? Does it hurt? Does it take a long time? I've heard this, nobody really knew. And so, which was part of the reason why I wanted to share this as like a series on the news, because I was like, well, I mean, we should be talking about this. Like a lot of people are doing it or thinking about doing it. So can you take us through the process? What is it like? I mean, you're giving yourself injections. Okay. So this part of it to me, I was like, are you sure? Am I trained to be able to do this myself? Like, I don't know.
Yeah.
Has that part gotten any easier, or has it changed at all in the last 10 or 20 years?
That's a great question. I think that it's still very similar process to what you did before in terms of taking the medications. I'm glad to hear that you said you felt like it wasn't as overwhelming as what you thought it was going to be.
Because people like really freaked me out. They were like, oh, you're going to feel so tired. You're going to feel so bloated. You're not going to be able to work out. Like, but really, I was like, oh, and especially back then, I was like, no working out. Are you kidding me? I don't know about this, guys. Like, but I was fine. I was going to yoga classes. Again, I know everyone's
and
different.
I think that's most people's experience.
Okay.
I mean, I think some people can have more side effects than others, but the vast majority of patients I talk to have an experience kind of like yours, where they are a little nervous the first night or two of doing injections themselves, and then they'll come into clinic and say, okay, that wasn't actually as bad as I thought it was going to be. I feel like I've kind of got the hang of it.
Yeah.
And most people are able to continue doing their normal activities, doing some basic exercise and things like that. I think that that's probably the more common experience.
Okay.
In terms of timeline, I think most of the process is done within a 2 to 3 week period. It's certainly it is a commitment, and it's a decision you're gonna have to come in and do appointments for ultrasounds and blood work and the procedure itself. So I don't want to take that lightly. That is a big commitment for a patient to make, but it is a fairly short period of time for patients to undergo the process.
And I know, like, back then, part of the trickiness of doing all of this was people saying, and I had an off or kind of fluid work schedule, but a lot of women I've talked to are like, oh, I never have to tell my boss I'm doing this because I have to keep going back to the doctor's office. Like, is that going to change anytime soon, do you think? The number of times when people will have to come into office and continue to track everything?
I mean, potentially over time, that would be really nice. I think, the thing that I think is positive about it, you shouldn't have to feel like you have to tell your boss about, medical procedures and things you're undergoing. But that kind of brings me to the idea that actually having fertility benefits is more and more common, that companies are opting to have health insurances that will incorporate having fertility benefits so that people can do things like egg freezing. I feel like it's actually becoming much, much more supported in the like corporate world.
Yeah, certainly in the last 10 years for sure. Yeah. Okay. And then so the egg retrieval process, I mean, you're out, it's like so fast.
It's like 15 minutes.
10, 15 minutes. When I came out of it, of course, not that day, but like the days later, I was like, yeah, there was more of a heaviness and you feel kind of sluggish and bloated. I think that was probably more anesthesia related than anything
And some of it too, I mean, your ovaries are bigger than they normally are. I always tell patients, you're like noticing your ovaries for the first time when you wouldn't really normally feel your ovaries. So that's normal to have those kinds of symptoms, very common.
And is there like people I remember would like the first question people ask is, how many did you get? Like, I'm not going to tell you. I mean, enough, because all you need is one. That was what I was taught very early on. All you need is one. But I remember I had a friend who got like 50 or something. I mean, it was like dozens and dozens. And I was like, should I be jealous of this? Like, I don't know. I don't know how to take this. Does it matter?
It's so really common to feel that, oh my gosh, how many should I have? And how many should I freeze, and comparing to what other people have experienced. It's important to realize everybody's egg count is different. So when you go through the process, the first thing is going to be coming in and meeting your physician and talking about egg freezing and doing an ultrasound, assessing your uterus, your ovaries, but doing a blood test called an AMH, that is anti-Müllerian hormone, that gives you a sense of your number of eggs that you have. We can't tell you the number of eggs you have down to the single egg, but generally the test tells you if it's like average, high, or low. And so based on the number of eggs somebody has is a really good, I think, idea of how many they're going to get at the time of an egg retrieval, though you don't know until you've gone through the process. It's true, all you need is one egg, in the sense of it's one egg and one sperm that are going to make an embryo that someday become a baby. But not every egg is going to be of good quality, and not every egg and sperm that fertilize become an embryo. Not every embryo becomes a baby. And so having more eggs is helpful in terms of increasing your chances of success. Unfortunately, there's not a number that's going to guarantee pregnancy in the future. And I always think that's something really important that, physicians should make sure that they're really counseling our patients on. That I do think, egg freezing, that embryo freezing, fertility preservation is a wonderful tool and resource, and I think helps people have reproductive autonomy. but it is not an insurance policy. It's not a guarantee that someone's going to have a baby in the future, but certainly increases somebody's chances of that if and when they decide to use them.
I remember a while back that the percentage, the success rate, I guess, if you will, was in the 20%-ish, 22% success rate. Is it still hovering in that region, or would you say that there's more success now due to technology?
So I think success in terms of like having a baby, I think with IVF is going to be really dependent on two things. It's going to be the number of eggs that somebody retrieves and then how old somebody is at the time in which they retrieve eggs. So that test earlier, the AMH test, tells us the quantity of someone's eggs, but not quality. And quality is really driven by how old someone is. And so it's hard to say if it's 20%. It depends on the individual, right? It depends on how old they are, how many eggs they have retrieved, and what that looks like. And so that's why having a higher number of eggs frozen at a younger age does help improve someone's chance of success.
Yeah. I mean, the math is mathing the way that you are describing it. Okay, so where does it go different if you've got a partner and then you're freezing embryos?
Yeah.
Because I feel like the egg retrieval, you're done, they're frozen. My friend, one of my friends and I was about to say her name. We were like, yep, are your baby eggs still on ice? Yep, I'm still paying rent for my baby eggs. But then there's a difference then at some point for people, again, who are freezing embryos.
Yeah, so, in terms of deciding whether to freeze eggs or freeze embryos. So certainly I have couples who come in, they decide, we don't know if we want to freeze embryos, we want to just freeze her eggs. I think when it comes to IVF, like I said, not every egg is going to fertilize and become a baby. So whenever you decide to freeze embryos, you're a little bit further in that process. You have a little bit more knowledge of what is frozen in the bank, for lack of a better word. So you maybe have a little bit more confidence that what you have frozen is actually more likely to end up becoming a pregnancy or a child in the future. So really the difference in the process is that day of that egg retrieval, sperm and egg will be combined, whether that's from somebody using donor sperm or they're using their partner's sperm. And then over the course of the next week, those embryos are watched in the laboratory, and then those that make it to the final embryo stage, called a blastocyst, those are frozen. I think many years ago, people would say that frozen embryos had a better chance of success compared to freezing eggs. I think technology's improved, and so eggs and embryos both, I think, do pretty well frozen in the laboratory. So I think both are really good options for patients.
Yeah. How do you counsel? I mean, is it just on an individual basis? What is the best route to go?
Yeah.
It depends on the couple.
I think it depends on the couple. I think it depends on what they feel comfortable with. I think that's the biggest thing. I think it's hard to make a sweeping statement about what's the best option. I think it depends on what they feel is the right option for them.
Is age considered in that counseling session?
I mean, not necessarily in terms of whether someone wants to freeze eggs or embryos, though I do think that if someone's older, like in their late 30s or early 40s, because there'll be fewer eggs that are of quote, good quality, they are likely to have fewer embryos and likely to have fewer embryos that are genetically normal to go on to be a pregnancy. And so they might decide to do embryos banking in order to have a better idea of what they have frozen.
Because, I'm just thinking now of someone who I've had conversations with, if she in her 40s were to freeze eggs and then you're trying to look for donor sperm, I mean, it just kind of prolongs the process, right? I want to ask you about GLP-1s in this realm, because a lot of people are talking about GLP-1s, but I haven't heard too much about GLP-1s in the intersection of fertility. Where are we in terms of the science? Like, is it helpful? Is it harmful? Does it matter? Are you hearing from patients saying like, hey, I'm on this or I'm on that, and will it impact it? Or do you suggest to people that, hey, maybe this is something you should look into? Because I do know that there's a correlation between weight or weight loss and success in terms of either conceiving or freezing.
Yeah, I mean, I think you're so right. It's something definitely I think that's becoming more and more talked about. I think GLP-1 agonist medications have been around for several years now, but I think have become just much more widespread in the general population. And that's why we're hearing about it more and more and getting a lot of feedback about the results that people have in terms of weight loss. There are studies that are going on right now looking at the impact of GLP-1 agonists on PCOS. So patients with polycystic ovarian syndrome classically have a much higher risk of having things like metabolic syndrome, so having high blood pressure, having high cholesterol, having diabetes or prediabetes. And so I think there's a lot of hope that potentially GLP-1 agonists could be beneficial for that patient population and may translate to things like weight loss and helping to improve fertility outcomes. So there's evidence to show that even small amounts of weight loss, like 5% of someone's body weight, can actually normalize somebody's cycles who may have irregular, unpredictable cycles, which may be common in patients with polycystic ovary syndrome. And so I do think that it's potentially a really good tool for patients for helping with weight loss.
Is it a conversation that you feel has entered the chat, so to speak?
Yeah.
Like, whereas 10 years ago, I was not talking about this at all.
Yeah.
So I'm curious, like, do you talk about this on a weekly basis or a monthly basis, would you say, with patients? Or
I think more where I see it is a lot of patients are already on these medications before coming to see me. They've already talked with their primary care doctor, with their OBGYN, and they're already being prescribed these medications. And so a lot of the conversation is about oftentimes really safety in pregnancy. So at this point, these medications are not considered to be safe in pregnancy. Patients should be stopping them when they do get pregnant. So that's oftentimes where I'm starting the conversation. But also talking about, I would say, weighing the pros and cons of focusing on weight loss prior to trying to get pregnant versus trying to focus on pregnancy now, and what is the priority. And so that may be different for different patients. So somebody who's younger in their 20s may feel like they have more time to focus on weight loss and getting to that I think eventual goal that they're trying to achieve, versus somebody who's in their late 30s or early 40s may say, I think that weight loss is important to me, and we talk about how it's important in fertility, but time is really important, and maybe that's something that we need to focus more on fertility treatments right now instead of putting everything into the weight loss with GLP-1 agonists, if that's going to mean that we're going to delay pregnancy.
Yeah. You said something interesting just now that I have not talked about this intersection. So if a medication has to be stopped, how soon in advance does it have to be stopped prior to like the IVF process?
So those medications in general for all procedures really should be stopped a couple weeks before somebody undergoes anesthesia. So separate from fertility itself, there's the way those medications work is they delay the contents of the stomach. And so it's kind of a slow transit of all of those of the food and everything that's in the stomach. And so it puts somebody at higher risk of anesthesia complications when they undergo a procedure where they're asleep. So for IVF, patients are often told to stop that medication somewhere around 10 to 14 days before the procedure. For a safety issue. And then if someone's planning for pregnancy shortly after IVF, oftentimes we tell people to stop at that point and then not resume prior to doing like an embryo transfer. Because hopefully we're moving into doing embryo transfer and moving into pregnancy shortly.
Yeah. What is one aspect of your field that you're kind of laser focused on, or you're leaning into, like, there's something really exciting going on here, and I can't wait to see how it unfolds or unravels, because you're really on the cusp of all this interesting research. And I know the physicians at Care Fertility are like at the forefront of not just research here in the United States, but always have their fingers on the pulse of what's happening worldwide. So, but I'm curious to know what pulls you, what's got your interest.
Yeah, I mean, I think part of what we talked about earlier, the in vitro maturation, I think trying to really focus on technologies that are going to minimize the medication burden that patients have, decrease side effects, things like that. Try to increase the access to care, I think, is really important. I think another thing that's really hopeful in our field that we're moving towards is really trying to increase the benefits and access that people have, whether that be through, state mandated insurance coverage, or just through more and more employers realizing how important it is to value fertility services in terms of what they cover.
What is the conversation, would you say, for like 30 somethings right now? What kind of questions are they asking? I feel like the last 10 years, really, we've come a long way from people not wanting to talk about this, or let's call it 20 years, to like being very open about it. Lots of even influencers sharing the whole process as it relates to, or when it comes to egg freezing. But like, what is kind of the word on the street, maybe in your friend circle or patient circles and things like that? What are people asking about in terms of fertility?
I think people ask about, what are things that I can do in order to try to improve my fertility? What are things that I can do and take control of? I think that's a hard one. I think that there is not, something very specific that I can tell somebody that's going to be this specific supplement or this specific, lifestyle thing to do. I think really focusing on a healthy lifestyle in general, though. I think trying to eat right, trying to exercise, I think not smoking, all of those kinds of things I think are really, really what people should focus in on.
What do you want people to know that you would say is like a common myth? Like, people think this way, but really what I want you to know is actually, here is the truth of it.
I think one thing I think that's really important to explain to patients, I said earlier, is I think that fertility preservation, egg freezing, is not 100% guarantee that means that those eggs will necessarily be a baby in the future.
Do they come in thinking that? Like, I am here to, yeah. Okay.
And so I think sometimes it's not even just a discussion about talking about someone's fertility preservation and just that process and egg freezing, but it's also about what is your timeline? What do you think your family building goals look like? And then even if somebody doesn't achieve a family with their eggs, they're frozen, or maybe somebody comes in having never frozen their eggs and is trying to get pregnant, doesn't get pregnant, it doesn't mean that there's no options, right? I think that what's really incredible about our field is that there's a lot of ways to build a family. And I think it's really important to talk about that with couples. And not every route is the route that everybody feels like is the right path for them. And so I think it's important to have that discussion and figure out what's right for each individual patient and couple.
Yeah. I mean, I've done over the last 10 or 15 years stories about embryo adoption, which a lot of people are like, wait, what? What is that? And I'm like, yeah, that's a thing.
Yeah.
Right. And then I've also, thanks to Care Fertility, I've done stories about the InvoCell, allowing same-sex couples to both carry, which, again, it blows people's minds when they first hear about it, because they're not maybe in the field where things have developed so quickly, and for the benefit of countless people, really. Yeah. Is there anything else that you want to add before I let you go?
I don't think so.
Anything we left off? Anything about egg freezing, embryo freezing? I mean, we could talk about sperm freezing if you want. Like, I don't know what that process is like. What is sperm freezing as difficult or involved as egg freezing?
No, it's not. And I think we talked a lot about like egg freezing from the perspective of people who feel like they're not in the phase of life where they're ready to have a child and think that maybe they would want that in the future. But then we've left out a significant group where it's patients who are freezing for cancer reasons. And so I think oftentimes we don't see men freezing for kind of the more social reasons, like we see women doing for egg freezing, but men certainly are freezing sperm when, they may be getting a diagnosis of cancer at a young age.
Okay.
Yeah.
And that's probably one of the first kind of actions that you can take before starting chemotherapy to preserve your fertility, and then go on with, because these diagnoses and the treatment plans are so, they're variable, but they're quite long, quite intensive, and things can kind of shift at any moment. So, yeah. Well, Dr. Katie Doody, thank you so much. Thanks for your time. Thanks for your insight and information. And I really do look forward to seeing how this field continues to morph and evolve, because I wouldn't have been able to dream of sitting here, 15 years ago, talking about some of what is possible now. And so my mind is going to be blown, I'm sure, 20 years from now, just to see where we are.
I agree. I'm excited.
All right. Thank you so much. And thank you for joining us for The Shift. I'm Sonia Azad. Don't forget to like, share, and subscribe. We'll see you next time.
Today's podcast is sponsored by my good friends at Care Fertility, and care should be thoughtfully personalized. With 2 convenient locations, their focus is helping patients move forward with clarity, confidence, and support.
And don't forget about our friends at Glam House Collective. Let's get glam.